Hello and welcome to the first HIV Justice Live, where we bring to life some of the big issues that concern us at the HIV Justice Network and discuss them with fellow activists and experts. Today we'll be asking the question, whose blood is it anyway, as we discuss whether public health surveillance of HIV transmissions using blood taken for HIV resistance testing risks doing more harm than good. And we have some brilliant minds on the show today. Canadian activist and academic, Alexander McClelland. Bringing an intersectional analysis, Khanna. With a global perspective, Amon. And talking with me about the science, the UK's Dr. Larissa Mulka. And first up is Alexander McClelland. Alex is a tireless HIV activist who moved into academia to further elevate his activism. He wears many hats, but one I really appreciate is his active membership in the HIV Justice Network's Global Advisory Panel. Welcome, Alex.
Thank you for having me here, Edwin. Always a pleasure.
Hi, so Alex and I, along with a group of amazing US and Canadian activists and academics, recently worked on an editorial together called We Are People, Not Clusters. This is all about molecular HIV surveillance. So Alex, without getting too deep into all the science and the ethics right now, can you give us a brief overview of what molecular HIV surveillance is and the main areas of concern as we highlighted in the editorial?
Yes, for sure. So epidemiologists, public health experts, and infectious disease specialists have been increasingly mobilized molecular-based surveillance techniques and seeking to identify, manage, and control a range of different disease outbreaks. So this is used in influenza, tuberculosis, and syphilis, and now it's being mobilized in HIV. And for HIV, the general aim of molecular HIV surveillance is to rapidly and accurately identify molecularly similar strains of the virus that can be connected into clusters, or what are called clusters, that may not be captured by other routine public health investigations or other epidemiological research. So for public health purposes, the idea of this new approach is to identify clusters rapidly in near real time. So the focus is in kind of a real time, where transmissions are taking place, and then to intervene with what are kind of framed as enhanced public health approaches to connect people to treatment, care, testing, or diagnostics. And a focus of molecular HIV surveillance is on communities that may historically have less linkages to public health institutions. So these are sexual networks of drug-taking gay men, migrants and immigrants, adolescents, pregnant women, people living in poverty or in rural communities, or in other locations where people living with HIV might not be connected to care. And all of this might sound really great to some people, except for the practice is being conducted without consent. So people are not aware that their blood is being used without their consent as a form of public health surveillance. The practice is being done without the consultation of people living with HIV. And it's done in a way that kind of objectifies people living with HIV as a risk to be managed. The problem, furthermore, is that the locations and where the practice is being deployed are global hotspots for criminalizing HIV. So, for example, in US and Canada. And in these contexts, public health institutions have a long history of working very closely with police and the criminal justice system. So the fear is that the practice will create greater precarity among people who are already ongoing targets of public health, of surveillance, for various different forms of surveillance, and it could put them at greater risk for criminalization. At the same time, this is being done without any consent.
Wow, so that's so helpful. I mean, that means there's so much for us to consider and discuss. But I think before we go any further, there are quite a few complex scientific terms and concepts here that need some explanation. So we're talking about molecular HIV surveillance, and this is based on the science of phylogenetic analysis. So earlier this week, I met with Dr. Larissa Mulka and asked her to help us understand the science.
Phylogenetics is the study of evolutionary history or relationships between individuals or groups of organisms, from which we can identify how recently or distantly related they are. So when HIV is passed on from one individual to another, The viruses are very, very similar, but over time they'll independently mutate, meaning their genetic codes or sequences become slightly more different over time. And when we compare these sequences within a phylogenetic analysis, we can identify the sequences that are most similar, meaning they're more likely to be recently related. And when we represent these analyses graphically, so within a phylogenetic tree or within a network, sequences that are more similar are more likely to group together in what we'd call a molecular cluster, which can be defined in different ways, but may show more recent or rapid transmission between individuals.
So what can phylogenetics tell us about HIV transmission?
So molecular clusters, for example, can be defined in different ways. As I said, they may show more recent or rapid transmission. And when we link these molecular clusters to additional data, such as the date of sequencing or clinical and demographic data, what we can look at are which factors are associated with transmission. So, for example, things like recent HIV infection. And we can also look at how HIV transmissions changed over time. So exploring the origins and potentially looking at where there might be outbreaks or hotspots of transmission.
What can't these clusters tell us?
Okay, so one important thing to note is that phylogenetics is very good at showing that there's definitely not been transmission between two individuals. However, it can't tell us for certain that transmission occurred between two individuals. And this is for several reasons. For example, it's highly improbable that we'll ever have a sequence for every individual within a transmission network within an analysis. And therefore, even if two people have very similar sequences, we can never say for sure that there wasn't one or more unsampled individuals, for example, if they were undiagnosed at the time, that were between them. So we can never show that transmission was direct between two individuals. Another thing with standard phylogenetics is it tells us nothing about the direction of transmission. So if person A passed it on to person B, or person B passed it on to person A. Some newer technologies, such as when using next generation sequencing, may be able to predict direction or directness with more accuracy. However, two recent robust studies have still shown that this can't be done in all cases.
So let's just talk about where these sequences actually come from. All these, the comparisons and the clusters, where do they come from?
Okay, so sequences are taken from blood of people living with HIV. And the majority of sequences used for phylogenetics are actually taken from sequences that are created for routine clinical care. So when people are diagnosed with HIV infection, they have what's called a resistance test. And this is taken because it shows whether there's any resistance to treatment. The sequences used for resistance tests are often stored within databases with semi-anonymized or anonymized data, and they can be used for phylogenetic analysis through public health organizations and researchers.
So you mentioned public health, and one of the things that we're going to be talking about is real-time phylogenetics and how public health is using real-time phylogenetics for molecular HIV surveillance. Can you talk a little bit about that? Yeah,
so phylogenetics has been used for public health for many years, but recent advances in our technologies and computational speed means that we can now perform analyses in near real time. So we can really see what's happening in an up-to-date way with HIV transmission. And one of the first examples of this was in British Columbia in Canada, where investigators used an automated phylogenetic system which reanalyzed data when new sequences were added to detect how transmission was changing in real time. And this led to public health action when a rapidly growing cluster was identified with several sequences with transmitted drug resistance, leading to discussion with the public health team. And from this, individuals with transmitted drug resistance were actually identified from the data and contacted for interventions such as antiretroviral treatment, re-engagement into care, and partner notification to try and reduce further transmission. Subsequent analysis did show that there was less transmission with drug resistance, but it's important to note that this was an uncontrolled study, and we can't really say whether these interventions, which should be part of routine care, would have occurred irrespective of whether the analysis was done.
So what do you think is the added value of molecular HIV surveillance when there are all kinds of standard interventions already?
Well, molecular HIV surveillance isn't itself an intervention. All it is a way of monitoring transmission to hopefully identify groups to prioritize for interventions. So interventions include things like engaging patients into care that have disengaged, starting treatment when people have a detectable viral load, and performing contact tracing when needed. But it's important to say these interventions really should ideally be part of routine clinical care for all.
So, Alex, let's start by talking about the example Larissa gave of British Columbia. The study claims that molecular HIV surveillance was useful to identify people with transmitted drug resistance and to help them get into care and onto effective treatment. I mean, what's so wrong with that?
There's nothing wrong with that necessarily, but I think there are ways in which these communities could be already targeted and already prioritized. So for example, I guess just taking a step back and looking at that study, I think Larissa gave us a good overview, but in BC, it's the province in Canada, a province in Canada where molecular HIV surveillance is rolled out routinely as part of the public health infrastructure. And so they have in their database over 9,000 HIV genotypes from over 9,000 people living with HIV in the province. And every day when genotypes are added, or if genotypes are added, the system updates itself and triggers an automatic analysis of the entire data pool and can identify specific clusters. So in 2014, the system identified a cluster of 11 new HIV cases that took place over 3 months. And so these were among young gay men, and some of those cases had transmitted a drug resistance. So public health intervened with enhanced public health follow-up, or what they said in the article, which was published in The Lancet in 2016, said they followed up with enhanced public health follow-up to ensure linkage to care and treatment initiation in the affected subpopulation. And so this all sounds good, but when you think of how actually the British Columbia public health institutions work, they actually work quite closely with police and policing institutions. And so enhanced public health approaches could mean engagement with police. And in 2018, actually, not related to this study at all, but public health institutions in BC worked collaboratively with police to enact a manhunt, tracking down a man who was apparently not taking his HIV treatment. And so when you think of public health institutions being deeply intertwined with policing and the institutions of policing, this is where this becomes concerning, where in a country which is known around the world as a global hotspot for criminalizing HIV.
So your colleague from Canada, Patrick O'Byrne, actually did a study about the impact of HIV criminalization. And we made a documentary called More Harm Than Good, where we interviewed him about what happens when people conflate public health and healthcare with policing. Let's watch.
And a resounding theme was nobody could make a distinction between the public health department and the police. It was a single institution. And this is problematic, right? How can you provide healthcare services when people think that you are a police agency? And they would say, I regret doing testing, right, with a public health nurse, now knowing that, right, they would hand it over to the police if they found out I was, right, not disclosing my status. How do you provide care when people won't access it? Right, so the people who are supposed to be there to do HIV prevention can't. They absolutely cannot, because you can't provide services to people who aren't in clinics. And if they're not in clinics, then right, what are the health professionals supposed to do? Absolutely nothing. Like, the laws have effectively rendered your HIV prevention health professionals, right, useless.
So do you have any questions for Alex? If you're watching this live on Facebook, you can write your question as a comment directly under the live stream, and my co-host, Rebekah Webb, will be passing on your comments and questions after we've talked with all of our guests, and we'll try to answer as many as possible live. So molecular HIV surveillance isn't just happening in one province in Canada. It's already been fully rolled out across the United States. And to learn more about what this means for people living with HIV, we're now joined by Khanna, Executive Director of Positive Women's Network USA. Welcome, Naina.
Thank you so much for having me here.
So, Naina, molecular HIV surveillance has rolled out. The CDC has rolled this out across the United States. Tell us what that means for people living with HIV, and how did it actually happen?
Yeah, thank you, Edwin. Great questions. And I think it's really important for folks to understand, especially our viewers who may be dialing in from, various parts of the globe, and also for people in the US who don't work in the sphere of HIV every day. I think it's really important to start by understanding the context of HIV in the United States. And so HIV in the United States is a pandemic that disproportionately impacts Black and Latinx people. It is an epidemic that disproportionately impacts folks who are low income, people who are housing insecure, people who are food insecure, people who use drugs, people who need to trade sex for safety sometimes, and for housing and basic survival needs. And so, and in the United States context, these are communities that are already independently of HIV policed, surveilled, and criminalized. And so in the US, many are surprised to hear that molecular HIV surveillance is something that is already very widely used. So it is not new. However, there's been a dramatic expansion in molecular HIV surveillance. And part of that happened through the current occupant of the White House's new End the HIV Epidemic plan, which was released in the beginning of 2019 in the State of the Union speech. So the occupant of the White House basically announced this large federal plan to end the HIV epidemic domestically. And that plan rests on 4 pillars. And one of those pillars is molecular HIV surveillance. So the plan basically calls for an expansion of diagnosis of HIV, treatment of HIV, and response to HIV. And the response to HIV portion depends critically on this technology called molecular HIV surveillance. This was quite a surprise to many people living with HIV, including myself and the networks I am part of, that are led by and for people living with HIV, and that advocate for one of our core principles is nothing about us without us. So, this is fundamentally an intervention about our data, about how our data is taken and utilized without our consent. And so we were quite surprised to learn, first of all, that this had already been happening, that this has already been happening without our consent, and that as a result of the administration's End the Epidemic plan and some guidance from the Centers for Disease Control and Prevention that came out a year before, that molecular HIV surveillance is something that is now actually required by CDC for all health departments that are funded to do HIV prevention work. So this is something that is used across all jurisdictions now, funded by CDC. All jurisdictions have been required to develop plans around this. And in some jurisdictions, we know that they already have 60 or 70% of the data from people living with HIV. And so, so that's a little bit about how widespread it is. And I'm happy to talk about some of the specific concerns and issues with it as well.
So was there no consultation, no dialogue between people living with HIV and the CDC, Naina?
No, there was no consultation done with people living with HIV or even with real community-based stakeholders around this process. communities were quite surprised once we learned that this had been happening not only without our consent, but without our knowledge, that this was already, molecular HIV surveillance is already well underway. Our data is being collected, shared, stored, and there have been no assurances provided by some of the federal agencies that are responsible for this around how that data really is protected, even from other federal agencies. And I think it's important also to contextualize that in the United States, we are very much in an emerging authoritarian and fascist regime that has taken deliberate steps to target, criminalize, and police increasingly Black and brown people, migrants, has proposed specifically to deport or fine immigrants based on having an expensive health condition, an expansion of our public charge principle. And so this is really a problem. We have had situations where clusters were identified by what they call clusters were identified by health departments. That information has been shared with the media. And so we had an instance in a large Seattle newspaper where an article actually ran with a headline that basically said, there's an HIV outbreak among people who are unstably housed, who are like staying on this specific street. So that is a recipe for not only criminalization and law enforcement and things like that, but also for community-based violence. Mm-hmm. It puts a direct target on people's backs, and particularly trans folks, particularly people of color in the U.S. who are already subject to all different kinds of surveilling and policing, which disproportionately targets some communities. There are wide variations in terms of how data can be shared with law enforcement, with immigration enforcement. There's not consistency jurisdiction to jurisdiction and what these sharing practices can look like. So one of the questions that, for example, we have explicitly asked CDC is, how is this data that you're collecting? What's the firewall between you and the Department of Homeland Security, which is, who runs ICE? And I think we're all aware that there have been, many increased activities by ICE, by immigration enforcement under this current regime. The CDC has declined to answer that question for us in any type of way. And then there's also this issue of, allegedly this data is being collected to support interventions in the field. Well, who's doing those interventions? Mm-hmm. How well are they trained in the nuances of stigma and criminalization and competency and violence that people living with HIV and communities most vulnerable living with HIV are very much at risk for? Mm-hmm.
It's shocking on one level, but on the other level, knowing what's going on with your administration, perhaps not so. Now, I know both of you are leaders in pushing back, and I'd like to ask both of you, start with Naina and then Alex, about what advocacy is going on right now, first in the US and then in Canada.
So, in the US, the advocacy to protect people against from this molecular HIV surveillance and the potential consequences, which include criminalization, deportation, that advocacy is being led by the networks of people living with HIV. So it's being led by Positive Women's Network, the Zero Project, Thrive SS, the U.S. People Living with HIV Caucus, as well as a number of allies who are in the academic realm, in the research realm, and other policy spaces. And the advocacy has really been centered around identifying what are the core set of data privacy protections and other types of protections that should be in place in order for molecular HIV surveillance to be a safe technology to use for our community. There have been some efforts at sort of doing a scan of the legal and data privacy environments within the U.S. The environment varies literally state to state, and sometimes enforcement depends on how well the public health department actually understands the law. So we've also talked to people who are leading public health departments who are confused about whether they are required to respond to a subpoena versus a bench warrant from a judge. So they're not clear about when they actually are required to share data in a criminalization proceeding, for example. Mm-hmm. That is extremely dangerous as well.
Absolutely. And Alex, is this a similar work going on in Canada?
Yeah, well, I think one of the things that public health professionals are saying when we respond to them is that we're looking only at molecules, not people. And I think one of the things that activists are trying to do is say, no, this happens in social context, in the real world, and people are connected to molecules. And those people are under regimes of surveillance and regimes of criminalization. And I think this is one of the things that activists all around the world are trying to work on. In Canada, there hasn't really been too much pushback, but people who are working on HIV criminalization are highly concerned because of how often our public health institutions collaborate with police. And public health institutions, similarly, like Naina was just talking about in the US, the oversight is different in each place. In many places, it's only the purview of one medical officer of health. There's no court that oversees it or no other body. It's just one individual who can decide when and how to share information and when to enact legal orders against people or when to participate with the police. So the oversight is really lacking. And even our understanding of where this is taking place is lacking. And one of the concerns is that the technology has become increasingly cheaper to use. So it could be deployed really rapidly across many places without us knowing. And so one of the things in Canada is kind of trying to raise concern about this and engage in academic debates around it. So responding like we did with the article that we've all collaborated on, kind of intervening in international debates on this to kind of put the practice into question.
So for now, Alex and Naina, thank you so much. If you have any questions for Naina or Alex and you're watching this live on Facebook, you can write your question as a comment directly under this live stream. So we've heard a lot about the US and Canada. During my earlier conversation with Larissa Mulka, we also talked about a recent study she did in the UK, where molecular HIV surveillance is not currently routine public health practice. And that was undertaken with community involvement, including with us at the HIV Justice Network. As far as I'm aware, it's the first study anywhere in the world that actually asked people living with HIV what we think about molecular HIV surveillance. So Larissa, what was your motivation for doing this acceptability study?
Well, I'm a physician working in HIV and sexual health, and I've always had an interest in HIV prevention. And I actually started a PhD looking at the use of phylogenetics to guide public health interventions because I was really excited by all the opportunities that it offers. But also because I'm a physician, I'm very aware of issues around confidentiality, stigma, and sometimes blame that can affect my patients. And looking into the potential for these problems really gave me an interest within the kind of ethical areas surrounding this use. And I was quite surprised at the fact that we hadn't really spoken to patients about what they thought at this point.
So you enrolled some people living with HIV and some people who tested frequently into the study. And what did you find?
So I found that acceptability for the use of phylogenetic to guide interventions was very individual and very much based around a balance between public health benefit and risk to the individual. So that was mainly through stigma or blame. And acceptability was greatest when public health benefits were highest, and also obviously when the risks were lowest, for example, when using anonymous data. But we did interestingly find that generally, even when using identifiable data, it was acceptable to use people's phylogenetic data if the public health benefits were very clear and also if specific safeguards were covered. So this including guaranteeing that any identifiable data would only be released to the direct healthcare team, ensuring data collected for public health purposes was only used for public health purposes, and specifically not for use in criminalization cases, ensuring that people had confidence in robust security measures, having an increased understanding of what their data would be used for and what the opportunities and limitations of phylogenetics are, and also having the option of informed consent or an opt-out option. Many participants mentioned that without these safeguards in place, they felt that many individuals might be reluctant to test for HIV and also may end up disengaging with HIV care.
So, could molecular HIV surveillance do more harm than good if it means people are reluctant to test for HIV, and those of us living with HIV are so afraid that we disengage with our care? Can all of those safeguards that Larissa talked about ever be met? So to bring us a global perspective and to talk more about the ethics of molecular HIV surveillance, I'd like to welcome our next guest, Jo Amon from Drexel University in Philadelphia. Jo trained as a molecular epidemiologist and worked at the US Centers for Disease Control before spending many years at Human Rights Watch. And Jo is currently co-chair of the UNA's reference group on HIV and human rights. Welcome, Jo.
Thanks, Edwin. It's a pleasure to be here.
So, Jo, you were watching Larissa's video backstage where she mentions all of those safeguards that would be needed to make molecular HIV surveillance acceptable to people living with HIV. Are all of those safeguards possible to implement anywhere in the world?
You know, I think this is the key issue. I mean, we've talked a lot about people, they want to contribute to public health if there's a level of trust and protection that's provided. And so it goes kind of far beyond what you can do in an ethics review or an institutional review board kind of setting. But to establish that trust and establish that protection is what's really critical. And what we've seen globally is that, whether it's molecular surveillance or whether it's just clinical clinics that are serving populations that are often criminalized, there are threats and there are risks to those populations. Medical records can be, clinics can be stormed by police. In Uganda, for example, that's happened. In Kenya, mobs have shown up outside of clinics that are serving gay men. And so there's a lot of ways in which we need to build this from the start and not just look at this as a silver bullet technological solution that's going to end the epidemic.
So you've mentioned a few African countries, and you and I were members of the Ethics in HIV Phylogenetics Working Group convened by Pangea, the Phylogenetics and Networks for Generalized Epidemics in Africa group. And we published this paper a couple of years ago with recommendations for safeguards around molecular HIV surveillance for research. But isn't there a big difference between obtaining informed consent for research projects and rolling out molecular HIV surveillance using blood obtained during routine clinical care, especially without our consent?
Absolutely. And, even in research settings, you've got a wide range of how institutional review boards will view this issue. You've got a wide range of how researchers will respect the feedback that they get, the protections that they may put into their protocol and then follow or not follow. I was looking at one study from China that was published in BMC Journal of Virology, and it said specifically that they got the consent of participants for their demographic information. And it was a phylogenetic study looking at networks and clusters and transmitted drug resistance, and it didn't say anything beyond consent for the demographic information. And I think what that meant, even though it wasn't explicit, was they were already collecting all of the phylogenetic information, and then they called people in based upon the information they had, and then they just asked them if they had consent to their demographic information being given. But that doesn't make sense. That doesn't give people the information they need to make a choice about consenting. I think everybody wants this information to be useful to help guide a broader picture of understanding where the epidemic is going, what populations are being reached and what populations aren't being reached. But there's a risk really of bad actors kind of creating such a fear around this that people, as Alex said, as Naina said, will not want to come forward at all for care or for testing.
So where do we go from here? And to our live audience on Facebook, if you have any suggestions or questions, write them as a comment directly under the live stream. So really, for the three of you, how can we push back on what's happening in the US and Canada to begin with? How you've starting the advocacy, Naina and Alex, but how do we actually make sure that people living with HIV start to feel safe?
Well, I don't think that people living with HIV should feel safe. That's the bottom line. Like, we are not safe. And our communities are not safe because most people living with HIV, again, are, are Black people, are non-Black people of color, are low-income folks, are people who are at like multiple forms of risk and violence, including our president getting up in a debate last night and literally calling for another round of white supremacist violence. So absolutely, I don't think people living with HIV should feel safe. I think that the part of the problem with the entire premise of molecular HIV surveillance and the interventions that it seeks to deploy are that they rest on, again, still this individual behavior-based understanding of intervention. And we have the opportunity in the US, we are still, for all the things going on in the US, we are still arguably one of the richest countries in the world with a huge amount of resources. There are structural interventions that we should be making rather than going out and trying to find one person who is at the core of a cluster or relying on this type of data tracking and surveillance that is so invasive without any consent. So what do we need? We need universal health care. We need full protection of people's human rights. We need people to not be policed on the basis of poverty, lack of housing, engagement in survival sex, use of drugs. We have a system where we use the criminal legal system to respond to a whole set of issues. And by the way, this is also emerging as a huge issue around COVID-19. Mm-hmm. So these same types of tactics are very much being deployed. And for anyone who doesn't think molecular HIV surveillance is their problem, well, I have bad news for you around what is happening with the surveillance of COVID-19 and the way that Black and Latinx communities, again, are being disproportionately targeted and policed on the basis of quarantine orders and shelter-in-place orders and having to wear ankle bracelets and having private health information shared with first responders before they even show up at their door.
Alex, I know you're also monitoring what's happening with COVID surveillance and punitive responses. Do you have any suggestions on how to fight back, or how are you doing it?
Yeah, well, I think understanding molecular HIV surveillance as something that is a symptom of an ongoing problem in public health, and the way that public health conceives of people living with HIV as not part of the public. We are conceived of as a risk to be managed to protect the public from. And I think, so any harms done to us, violations of consent or criminalization, are not harms done to the public under the eyes of public health. We are people that the public is to be protected from. And I think one of the advocacy aims around this is to reshape public health and abolish practices of public health which objectify people living with HIV as objects, and rather to reshape public health to engage with us as active people, active agents who can collaborate collectively on ensuring the health and well-being of everyone in society. So I think this is a long kind of problem with how public health is conceived of people with communicable diseases in general. And I take inspiration from movements of people working towards data justice, so Data for Black Lives in the US, who is working to ensure that communities of Black and Indigenous people have access and control and possession over data about their lives. So I take inspiration from them, and I also take inspiration from activists working against technological determinism, such as facial recognition activists who are working against the use of technology such as facial recognition and ensuring that it is banned places because it is doing more harm than good. And I think molecular HIV surveillance activists can take inspiration from people responding to things like facial recognition, and also communities working to get access and control over data about their lives.
Joe.
And if I could just briefly add, sorry, I think what we need is we need a moratorium on molecular HIV surveillance as a practice until these surveillance and criminalization issues are worked out. We're not saying that this technology never potentially has a place. It may, although I personally think that is debatable. But there absolutely must be a safe, legal, and criminal legal environment for the technology to be deployed. And I think this idea that that people living with HIV have always been perceived as a danger to society. This is part of the sort of like deployment of that narrative as well, where we are people to be controlled, policed, to protect others from. And actually, if you look at the majority of studies show that people living with HIV, by and large, take actions because we do not want to transmit HIV to anybody else. That is well documented in the literature. What we need to be able to do that is healthcare access and access to treatment without copays and no broken system, and not experiencing stigma and violence and a lack of cultural competency at the hands of our healthcare providers. So those are the types of interventions that people living with HIV really need. And those are the types of interventions that will keep our communities safe.
Well, yes, I totally agree. Joe, are there any lessons for other parts of the world from what's happening in the US and Canada? It currently, molecular HIV surveillance is maybe part of a number of research studies, but it's not yet been rolled out. What can we learn?
Yeah, I wanted to start actually with a lesson that we could learn from the US. 15 or so years ago, I was working at the CDC on hepatitis molecular surveillance, and there was consent. There was a greater public health purpose, but it's a different disease than HIV, right? It was hepatitis A. We were identifying populations that were at highest risk or transmission via food chains and imported produce. And the context here is both addressing the risks around the technology and the ways in which the technology can be tied to criminalization, but also on not suggesting that this is the only way we're going to solve the HIV epidemic, right? It's about really kind of coming together and fundamentally addressing the ways in which criminalization and discrimination and stigma, are undermining our every effort and ignoring them and saying, oh, here's this other technological solution that's going to get us out of this problem, it's not going to go forward. Now, globally, I think there is a kind of potential that countries like China, for example, that already do a lot of surveillance of people who use drugs. There's specific public channels. If you want to get access to methadone, for example, you have to consent to be a part of research studies. You have to get HIV tests that mean that this is going to be really implemented without much protections at all in that context specifically, but in a lot of other contexts as the technology gets easier to use, cheaper to use, and as people start, figuring out that they can use it for means that aren't about public health, but are about population control and targeting what are called hotspots, which is also part of this disastrous language we have around the HIV epidemic. That doesn't put people first, but identifies people as vectors and as in need of control.
Okay, so thanks, Joe, Alex, and Naina. Now we want to hear from you, our Facebook audience. So I'd like to bring in my colleague, Rebekah Webb, who's the HIV Justice Network Senior Associate and who's been monitoring the Facebook comments. Welcome, Rebekah.
Some really strong reactions from people joining us on Facebook. People are expressing strong alarm and concern. Kanishi says, it's alarming for us. I have lived with HIV for 2 decades and my consent has never been properly received for this. She said it's alarming that a person or one person can share information to cause harm with this process. We need our voice to be heard on what we want. And we've been joined by Mark S. King, who says, yes, we are perceived as inherently untrustworthy. I don't feel safe as a person living with HIV, and I'm a white cis man. Thank you for highlighting this topic and educating us. So some real concern. Another one said, I remain deeply concerned that cluster analysis is done from laboratories performed by a doctor. What a barrier to folks accessing healthcare and building trust with a medical provider.
Yeah, thanks, Rebekah. So, I mean, how do we build those bridges with public health departments, with healthcare providers, some of whom may unwittingly be participating in this, but others who may actually want to be controlling and happy to punish people living with HIV? How do we build those bridges? Alex, do you have any answers?
Sure. I mean, I think one of the things to think about is that the people kind of deploying molecular HIV surveillance currently think that they're doing it as a benevolent thing to help intervene in HIV transmission. So they think they're doing a good thing, and I think one of the aims. So they're trying to do good. They're not trying to do harm. And one of the things that we're doing as activists and scholars is trying to highlight that the good they think they're doing is actually going to cause harm in our lives and will increase precarity, will increase surveillance, and could increase state violence for people. And I think getting that message across is something that we really need to work on. So having interdisciplinary conversations and getting people who practice molecular HIV surveillance on board to listen to us and hear us is one of the biggest things. I think since the beginning of the HIV epidemic, people living with HIV have demanded a seat at the table and have worked on getting their voices heard. And this is one instance where this practice was rolled out without any consultation, without any discussion, without people living with HIV, and is done on communities where people aren't even from that community. And so I think that concern that Barb mentioned, there's doctors in a laboratory who are probably cis white men studying trans women in Los Angeles who have no connection to that community, and then they're making assumptions about how those communities operate just by looking at molecules without understanding the social context, and that's extremely problematic.
So, Naina, have you been successful at all in having dialogues with the CDC or maybe with state public health departments?
Yes, thank you. So I think part of what we've found is that the public health departments and sort of like leaders of public health departments vary in what they think about molecular HIV surveillance and their understanding of the critiques. And we have certainly connected with some public health leaders who are very concerned about the deployment of MHS and particularly concerned about the vulnerable communities that have been mentioned. Others are a bit less, connected. And I think sometimes, as Alex is saying, sometimes it's not malicious, a malicious effort. It's that they don't know or understand the context. As I actually I was in a meeting with the lead surveillance person from a Midwest state that has a very high level of HIV criminalization cases. This person had been leading that surveillance division for about 20 years. She did not know what she was allowed to not share with law enforcement upon request. And she also informed us in that meeting that she had never met a person living with HIV until like 2 years before that meeting. And she had been leading the surveillance department for, a couple of decades. So I think that, from like there are individual people involved in these decisions, making decisions that really have life-threatening consequences for their constituents, and they don't always understand those. And I think that Alex's point that those most impacted by the decisions must be at these tables driving the decisions and driving the context in which these decisions are made is absolutely critical. So we've had some success in building alliances. We also have been able to successfully elevate this issue with a number of other federal policy and advocacy partners, although it is still continuing to be driven primarily by the networks of people living with HIV and some other human rights activists. We have also met with Dr. Redfield, who is the director of the Centers for Disease Control and Prevention And unfortunately, he does not seem to really understand the gravity of this issue yet.
Joe, Naina earlier on mentioned the idea that asking for a moratorium on molecular HIV surveillance, which is one way to go. But from an ethics point of view, can people living with HIV actually go to their clinic and say, I withdraw my consent to use my blood for molecular HIV surveillance?
So the problem is a lot of this surveillance is seen not as research, but as public health practice. And that's where they say, oh, this doesn't need consent, it's routine, it's part of the practice. Also, there's exceptions to kind of consent and to ethics protections when there's a emergency, like a public health emergency. And so some departments may be characterizing it that way. To me, the issue is we've been here before, right? I mean, we've had polarized debate about consent around HIV testing from the start of the HIV epidemic, and the kinds of ways in which everyone kind of pulls apart and blames each other for, activists are preventing this powerful tool or this knowledge of your status is not productive for anyone. And I think what people are saying is, people living with HIV want to contribute to knowledge that will end the epidemic as much as researchers do. There isn't a difference of overall aims here, but there has to be respect and there has to be trust. And you can't just say we're going to go, boldly forward without consent, without respect, without trust, and ignore the voices of people who are directly affected. And that to me is a much larger issue than kind of parsing out what bioethical principles are and what bioethics scholars think about this issue, because it's about people. It's about fundamentally changing our orientation to the response, about respecting those who are affected, and about moving forward together effectively to end the epidemic.
It's clear from what we've heard today that molecular HIV surveillance is a growing concern, not only in North America, but also around the world. The HIV Justice Network already monitors what's happening with HIV criminalization globally. And now we want to start monitoring what's happening with molecular HIV surveillance, particularly outside North America. So we've set up a special email address, mhs@hivjustice.net. So if you're watching and you're aware that molecular HIV surveillance is being rolled out or even just being studied where you are and you're concerned about it, please let us know. If you want to learn more about the work we do on HIV criminalization, visit our website, hivjustice.net. Our latest news story is all about molecular HIV surveillance. And if you want to see this show again or share it with friends and colleagues, it will be available on our YouTube channel tomorrow. So I'd like to thank all of our guests today, really amazing insights from Alexander McClelland, from Naina Khanna, Joe Amon, and Dr. Larissa Mulka. Thank you also to everyone on the HGN team, especially our director, Nick, and to Rebekah, of course, and to the Robert Carr Fund. And of course, to all of you for watching and participating on Facebook. See you very soon for the very next HIV Justice Live.